All right, we have everyone here. So thank you everyone for joining us today for this chat with Babylon Health. We have a lot of exciting topics planned for you today. Just to make this as interactive as possible, if you guys could turn on your cameras, that would be great. All right, so Aman and I will be hosting today on behalf of the Healthcare Club. Today on the panel, we have Eyal Dahan. He is the Director of Experience Operations at Babylon. We have Dr. Umang Patel, who's the Managing Director of NHS Services. And we have Dr. Keith Grimes, who is the Clinical Digital Health and Innovation Director at Babylon. In terms of the agenda, we're going to kick it off with some introductions from each of our panelists. We're going to jump into a company overview of Babylon. Then we're going to dive into some specific questions on the industry of telehealth and what's happening around COVID globally. And then we're going to continue on to talk about careers at Babylon, followed by an open Q&A. In terms of the Q&A, if you guys have questions, you can just type them into the chat. And then once we reach our last 15 minutes of open Q&A, we will use the chat to kind of facilitate the questions. And we want to have as much engagement as possible. So yeah, to get started, I'll just share my screen. Okay, so just to get started, if each of the panelists could give an overview of their role at Babylon Health and why they chose the company and their overall career journey to date. So Eyal, maybe we could start with you.
Sure. Hi, everyone. So my name is Eyal, and I've been in Babylon for almost 3 years now. And time flies. I've joined just after graduating from London Business School, where I did an MBA in the class of 2018. And I think the interesting piece about maybe my career path, and maybe we can elaborate a little bit more, before that I came with zero previous experience in healthcare. I'm coming from a more classic consulting background, and during my time in LBS, one of the understanding that I wanted to know is that I want to join a company that has a very significant impact. And once being introduced to Babylon, I would say that it was a match, and just understanding of the impact was quite self-explanatory when just joining the interview process. Since joining, I did several roles, all within operations. The first year was heavily focusing on building our UK service, specifically part of the NHS partnership that we have called GP at Hand. And over the second and third year within the company, I'm part of a team called Global Operations, where we look at our expansions to different regions, specifically within North America.
Great, thank you, Eyal. Dr. Keith, if you could maybe share your introduction as well.
Perfect. Of course. Morning, everyone. My name's Keith. I am the Clinical Digital Health and Innovation Director here at Babylon. My background is as a UK-based general practitioner, or a family practitioner for those who are less familiar with the term, from 2000, with a special interest in urgent and unscheduled care. And that was my kind of clinical background. But I've always loved technology. I went to medical school in 1990 hoping to build computers, you work with computers in healthcare, and it took an awful long time before that was even considered a thing that you could do, let alone where we are just now, where we're actively using it for digital health. I worked in innovation and technology within the NHS where I could for the best part of 18 years. And part of the reason that I joined Babylon is that innovation and technology within the NHS was akin to banging your head against a wall. It was very, very slow progress. There was a lot of resistance. And one of the wonderful things about joining Babylon with its, its fantastic mission statement, but it's actually getting ahead and going ahead and doing it. The practical application of these technologies is the thing that really drew me in. Once I came into Babylon, it's the opportunity to work with some really brilliant people and to continue my sort of lifelong learning, expanding my knowledge outside medicine and digital health into all the different areas has been a real joy and something that I very much enjoy just now.
And hi, my name's Umang. I'm a paediatrician, it's my proper job, and I went to medical school a little later than Keith. I didn't realise you were so old, Keith. But
It looks so beautifully young.
yeah, I know. It's let me know what cream you're using. But I joined Babylon 6 years ago as employee number 10. And the reasons I joined were twofold, really. I'm a paediatrician, like I say, and I was fed up of sticking plasters figuratively and literally on the problems that we'd faced and needed to get more upstream. And I thought sort of better leadership, better use of technology could do that. And then the second reason I joined was that I met Ali Parser, who's our founder. And without getting into the full details of it, he said, look, if anyone else is offering you the chance to pay off your mortgage and change the world, then great. But if not, I'll see you on Monday. And I'm here 6 years later.
I love that. It's inspirational. Well, thank you guys for introducing yourselves. So now what I'll do is I'll unshare, and Eyal is going to give us an overview of Babylon.
All right. So we'll spend the next few minutes just walking through the mission, what we've done up until now, and where we are basically heading. And I think this could be maybe a nice and good foundations towards, I think, the majority of today's time, which will be focusing on the panel. So I think as all of us mentioned before, I think the mission is a huge part for us in Babylon. And eventually the company has been founded with the mission to make healthcare accessible to everyone and everywhere. And when you think about it, the desire to do so comes from the fact that, we live in a world that I think that two drastic states that when I was doing my research on the company really came and were astonished to me. The fact first that we are short on roughly 5 million clinicians globally, and the fact that roughly 80% of the costs of primary care are coming from clinicians' costs, which means that in a way, to make healthcare truly more affordable and accessible, we do spend most of our time and efforts in rethinking on how healthcare is delivered. And this is what we do in Babylon. And specifically, we think about how can we better utilize technology to achieve our mission. So here is a little video to demonstrate exactly how we are thinking and how our solutions are walking towards that direction.
Hello, Louise. How can I help you?
Well, I've been feeling a bit dizzy recently.
I'm sorry to hear that. Can you tell me a bit more? Do you feel like the room is spinning, or are you feeling faint?
Yeah, sometimes it feels like the room's spinning.
And have you noticed any hearing loss?
Yeah, I have actually.
Do you have a ringing, buzzing, or humming sound in one or both ears?
Yeah, both ears. It's horrible.
Do you have any pain in your ears?
No.
Have you had a fever?
No, none.
Have you noticed any discharge coming out of your ears?
No.
Looking at your user graph, I can see you had glandular fever a few months ago.
Oh yeah, that was awful.
For how long have you been unwell with these symptoms now?
A couple of months.
Finally, have you noticed that your ears are feeling full or blocked?
Yes, actually.
I think I might know what's been causing your symptoms. It is most likely to be Meniere's disease, a condition of the inner ear that can affect balance and hearing. It could also be labyrinthitis, an infection of the nerve in the ear. Meniere's disease needs a specialist opinion and might be helped with some medicine to reduce the dizziness, so I'd recommend talking to one of our GPs.
Sure, sounds good.
Hello, Louise. How can I help?
Okay, so that was just a little demonstration showing how our Babylon brain actually works. And maybe it looks cool and exciting on the front end, but there's lots of both engineering and clinicians work behind it to really make the way that our triage operate and the way that our really AI agent is operating to be able to achieve actually the things that we are looking for, which is minimizing the interaction with clinicians wherever it's feasible and make sure that patients are getting the best care and the best time. So kind of quickly running through our services. So what you've just seen is a demonstration, and that's in a very, very high level. This is an effectively the first path in the patient journey within Babylon is our AI health services. This is kind of like the first layer. It's an AI chat-based service that providing immediate advice and support to our patients, and more importantly, making sure that the triage to the next stage, if there are next stage that are essentials, are effectively directed. Dr. Keith Grimes that is with us today is the clinical medical director that is overseeing this side of the service. So I guess he can share much more information about it in the panel discussion. But as we are fully aware, eventually you cannot solve everything in-app. You cannot solve everything through an health service, and this is why we are providing significant resources in developing our virtual health services or telemedicine services that are there eventually to provide to patients the right treatment by various type of clinicians whenever an interaction or consultation with a clinician is required. And in some cases, when physical examination is essential, we also provide a physical services. The nearest example to where most of you are is through our GP at hand service here in London and Birmingham, where we have clinics spread across those two cities. And although we would say that each one of those components is important and each one of those services is powerful by itself, the real value and where we are walking towards is to position ourselves in a place where each one of those layers is nicely connected to each other. And eventually we are aiming to create a holistic end-to-end experience where each patient is receiving the right treatment and at the right time to be able to first to be able to make it more accessible, but also more affordable as based on our mission. And when we look at our industry and we look where we are working to position or work towards ourselves, we are quite unique in that ecosystems in terms of the holistic service that we are providing, but also the scalability mindset and approach. We spoke a little bit more maybe about the UK up until now, but we already have quite a significant global presence. Here's a summary of where we are today. And I would just emphasize in saying that while we provide currently different services in different places, the mindset is equivalent in each one of those regions and countries that we are operating. It's eventually all around working towards providing an end-to-end holistic care to our patients. And we'll finalize with some numbers and facts. So when we talk about scalability, we already have contracts covering more than 20 million lives worldwide. In the US, we are responsible for the ongoing care and the cost of care for tens of thousands of Medicare and Medicaid lives. In the UK, where we are operating with partnership with the NHS, we are the largest NHS clinic, currently serving more than 90,000 lives. And I would say not less important, we are very proud that in Rwanda, we are central to the delivery of universal primary care. And that's something that we are providing to the entire population. It's supported by the Rwandan government, and it has been supported with a very close partnership with the Bill and Melinda Gates Foundations, and we've seen some outstanding results there in an environment that is quite different from what we've seen or what we are providing in the Western world. Some other numbers, so we currently hire more than 2,000 employees across the board. We've launched in 2014, and you can see also the funding that we've raised up until now. And in terms of volumes, we've completed more than 3 million virtual consultations, and we had more than 6 million AI interactions. And yeah, that's only the beginning. So I'll pause here and we'll move to the panel discussion. Thanks.
Great, thank you so much, Eyal. So I'll hand it over now to Aman to dive into the specific questions that we have for you guys.
Thank you, Eyal, for that overview of your company. So now we'll move on to the panelists. We hope to cover telemedicine as a whole, the trends in the past and the future, and see how telemedicine has an impact around the globe. So my first question would be for Dr. Keith. So before COVID-19, what were the biggest trends in the telemedicine industry?
Yeah, thank you. So the trends, it's interesting with COVID still an issue, both here in the UK and around the world. We're still talking about the peri-COVID situation, you know, the in-between time that we're dealing with the issues right now. And so it's interesting to look at what the state of telehealth was pre-COVID, during COVID, and then maybe get an insight into what happens after COVID. So if I'm going to answer first about what telehealth was happening before COVID, Babylon here in the UK, the penetration of video consultations was still relatively low. There's a really interesting statistic that was shared with me by Nikki Canini, who's one of the lead GPs in the UK. In November 2019, about 3% of UK general practices offered video consultations. Now they don't, they're very, very experienced in doing remote triage and telephone consultations, and there were some patches of people taking this approach, a digital first approach, by people going online and submitting what their issues are and then triaging them to the appropriate service. But it was very, very limited, and Babylon was, I think, the first in the UK to lead with a digital first general practice service with GP at hand, starting back in, I think it was autumn 2017. Umang might know a bit more about the exact date, but it was around about then. And it's fair to say, oh, hello, here we go. There we are, in there, the date. So
November,
there you go. And I was still working in general practice in the NHS at this time, desperately trying to put more video consultation in my practice. I tried to put Skype consultations with my patients back in 2014, and was told by my employer just to stop because it was medical legally not possible to do so. That, of course, turned out to be completely incorrect. When I spoke to my indemnity people, it was absolutely fine. And in fact, I did offer video consultations to patients, and they found it very, very useful. But the general approach was very, very risk averse, the idea that this couldn't be used. And that was absolutely the case prior to COVID. So moving on to COVID, all of a sudden with that arriving, there was a sudden change in what needed to happen. Patients could no longer really be seen face-to-face unless they were acutely unwell. So there was this massive demand to be able to manage people remotely. And seemingly overnight, people switched, or GPs switched, to going from no video consultations to using video consultations. And the follow-up statistic from Nikki on the availability of video consultations in English general practices was over 99% in July 2020. So you can see from 3% to over 99%, it was absolutely enormous change. And that was one of the most fundamental things that happened. Was that we had to see people remotely, so we facilitated that. Doctors and nurses were working from home, so there was this transition of people to start remote working. That almost never happened in general practices. There were some tiny little isolated pockets of that as well. And it looks like video consultations as part of the offering and the ability to work from home are here to stay. There are certain things that are manageable remotely. There are certain things that aren't manageable remotely. And so the steps that we've taken, and Babylon had taken some steps prior to COVID to do this, is to try and identify who needs to be seen. Does a person need to be seen first? And that's where I come in the work that we do with self-care products to help people care for themselves and manage themselves without the additional need for clinicians, but also direct them to the right place at the right time there afterwards and connecting them seamlessly. So pre-COVID and into COVID, those were the main changes within the industry. I'll pause there because there's definitely more to say about COVID and what's happening afterwards, but I'll leave it at that point.
Thank you so much, Dr. Keith. Just on that topic, Dr. Umang and Eyal, do you have anything you'd like to add to that on how COVID-19 has really disrupted the telehealth industry?
I think like Keith has been saying, I think it's really funny. We've been on this journey for a while, and before everyone was like, oh, you know, you're being disruptive. What are you going to do? Like, you know, this needs time. You know, you're blah, blah, blah. Don't go too fast. I think people always said, you know, you can't be like Facebook and move fast and break things. It's healthcare, blah, blah, blah. And then suddenly the pandemic hit, and then everybody was like, why aren't you ready yet? And you're like, what? Like literally sort of over a month or so, everyone was like, well, why aren't you ready now? I want all of these things ready straight away. And I think, you know, that's been a real shift. And I think it caught us a bit off guard, right? Like we weren't ready because you don't know what ready is. So the concept of just putting telemedicine in is not solving the problems that we need to deal to sort of address all of the underlying challenges of non-sustainable healthcare. You need to do all of the system change, like Keith's described already. And that takes years. And in the UK, for example, you know, there's been legislation that came out a couple of weeks ago to change all of that stuff. So there's a huge bit of it that goes, it just takes a certain amount of time. But it was fascinating that people are suddenly like, but like, why can't you just do this now? Like, why isn't your AI ready? So, you know, we can do it. And you're like, because come on, guys. Like, it's so funny how it's been chalk and cheese between the same groups of people we were talking to before now going, well, I want you to be ready as a consequence of the pandemic. And I think our view of it has been not to rush. So our view of it is not to say, look, do you know what? Yeah, fine, okay, let's have what we've got and take this. And, you know, I'll done this as a global operational thing is go, actually, we've got to do it safely. Because although you might have some pace now, we could definitely mess it up. So, you know, if we did something without doing it properly and it harms a patient or isn't safe and secure, then we go backwards way further than we might go forwards by trying to take advantage of the situation.
Can I also just follow up on that? It's an interesting point that simply putting a video consultation as an option isn't the solution. Umang's just made that very, very clear. And yet in some quarters it was seen as a solution. And what you're seeing right now is that if you incorporate video consultations or remote care without some of the underpinning changes, it can actually lead to quite substantial fatigue in the people that are using it as well. And you can sort of see this happening when there was a massive spike in the use of video consultation, and then it's falling back. And some people might say, well, actually, that just shows that it couldn't do everything. Well, it never could do everything. It was never intended to do everything. But equally, just adding that without making the changes to support the new ways of working, to have not just remote synchronous consultations at the same time, but asynchronous ones with messaging and using the full range of different communication methods. Without that, you're not going to be able to sustain it and actually move to that next stage, which is how care can be provided in the future.
So I just have a follow-up question on that, because it sounds like there has been then sometimes a little bit of a disconnect between the expectations of patients. And how have you been able to manage those expectations in terms of communicating with patients?
I think so. It's really hard to communicate with patients because patients don't really know. I think the thing that we've been on this, like if we've gone through this journey, is you don't need to do very much to be better than the current ways of communicating with patients. So typically traditional medicine is you come to me, you get sick, you come to me, and then I try and fix it. And it's all done on, it's sort of in our house, right? You know, it's very hard to get out. So as a pediatrician, you know, I wait for you to get sick and then I wait for somebody to refer you in and we deal with that. A lot of what we try to do with Babylon is pretty simple stuff, right? Like just let people know you've booked an appointment and here's the face of the doctor you're going to see. Here's a little bit of a background on them. So, you know, like, why can't you Google search your doctor that you're about to see and just double check that they've got the right competencies and stuff like you would if you were, you know, choosing an accountant or something else, right? Like the ability to do all of that stuff we tried to put into the app. So that was all pre-pandemic. And we've really just done more of the same. Like with the pandemic, we've not done much. We did launch a COVID-19 care assistant service, but it was effectively what we were doing before, just with a more of a COVID front end. It wasn't like actually, no, let's throw away what we were doing before and try and switch into something new, because like we're pretty convinced, and that we've all drunk the Kool-Aid here clearly, but we're convinced what we're doing was the right thing to do, and the pandemic sped that up. So it wasn't a case of we didn't pivot to try and adapt to, we were just like, look, okay, we've got to keep on doing what we're doing as competently and as fast as we can.
Yeah, and I would also just add to it, and maybe looking more from the operations experience side, that eventually I think in some extent it would be, I mean, eventually we are first and foremost dealing with people's life here as a service, so we need to be very careful when we think about pivoting, because even when you strategically make some kind of a shift, you're already responsible for tens of thousands of people's healthcare in the UK and globally. So that's something that is always bear in mind. We take in mind, and maybe compared to other fast, companies in different fast-growing industries, it's something that we always have to keep in the back of our head.
Thank you. So in terms of Babylon's approach to this whole changing trend, what were your key enablers that actually helped you succeed over the past year?
I think
you're going first, yeah. Sorry.
Yeah. No, I think one of the things was we were already at scale. So from a standing start, I don't know what we'd have done, but we knew what we were doing. We had the right teams in place, and I'm sure everybody that you talk to says this thing about culture, but we had a culture of getting stuff done, and that was probably the key enabler, right? Like there wasn't this, oh no, what are we going to do here? Have we got the right people? It was like, we're the team, we're going to get on and do it. And I think Eyal's team did the most work operationally, if you like, to make sure that we got, it wasn't just we had to move the doctors out, we had to run all of our operations in an entirely different way remotely. But culturally, it was very much like we're a scrappy startup, even though we're not really a startup anymore and there's oodles of us. But we still had that mentality of getting stuff done. When you take that versus a traditional health provider or a bigger company trying to change to adapt, I think that was a challenge. And like I said, and the second point was scale. So it wasn't like we were doing this and going, well, if we've got a choice, because we've only got 100 patients, therefore we could do lots of stuff manually. It was a bit like, oh crap, we've now got to do it because we've taken full responsibility for delivering that care.
Yeah, and it was I suppose this is people will often say this as well, but despite the kind of some moments of terror and unhappiness at the start of the lockdown, there's a real sense of kind of excitement and honor in working with a team that really did pull together. I mean, as we observed what was happening in Wuhan and we started to share the information across the company, even in early January, it was clear that something was going to be happening. And what the approach that we took, and I took as a doctor working inside the company, and it was mirrored in all the people that I work with, is that something is going to happen. How do we prepare ourselves to actually do something that is within our power to do so, to be part of the solution? Because we weren't going to be the complete solution. No, I mean, as we know, no one is the complete solution to this. But along the way, there was internally within the company, it was about configuring ourselves to be as responsive as possible to an ever-changing background. There was a great deal of uncertainty as well. Now, that was just within how we operated. But then when you think about the clinical service that we're doing as well, that changed. We knew very, very little about the disease at the start. And so what we had to try and do is that we had to try and build something, for example, our symptom checker. How do we get our symptom checker to help people understand whether they have COVID or not and what to do when no one knows what COVID is, no one knows what to do. And you have to do this in a way that you can't just mix it together and throw it out there. You still have to make sure it's safe. You still have to make sure that it meets all the regulatory standards as well. So there was this very, very intense period at the start where there was a concerted effort for everyone to do their part to streamline the work that they did, to still meet all the standards and find a way to flexibly respond to an ever-changing situation with information. I think it was very, very intellectually stimulating. It was quite hard work, but we were set up well to do that because our company had configured itself to be able to do this outside COVID for other challenges as well. We just changed the focus of it. So yeah, that was the early part of what we did.
Yeah, and I would just add, kind of on the same note, I think consistency was important. So I mean, in terms of strategy, it remained kind of the same. We've made some adjustments, as Umang was mentioned, to our service, but fundamentally the service was the same service, just making some customizations to the all of a sudden existing needs to our patients. But also in terms of our growth plans and expansions to the US, I mean, nothing really changed there. Maybe some things have been accelerated a little bit, but the mindset and this focus, as we were briefly talking before about the pyramid and having the services integrated one to the other, it was all there before. So it was maybe more about a little adjustments to the current environment than completely trying to shift away from our direction of travel.
Yeah, I mean, you guys were already on the trajectory. So I guess my next question, Dr. Keith, this is, you set the question up nicely at the beginning where you said there is pre-COVID, how it all changed during COVID, and then after COVID. So I'm curious, after COVID, now that once things start to go back to normal, how do you think the industry will look then? Do you think it's changed for good, or do you think people will prefer to have more in-person consultations again?
So it's changed for good. I don't think there's any going back to the way we were before. I mean, even if you park the technology side of things, COVID has forever changed the world, and we're going to be dealing with COVID for a long time to come. So as a society, we're going to have to adapt to that. But if we look at healthcare for the moment, I think everyone has seen what telehealth can do. And everyone has experienced telehealth, or very, very large numbers of people have experienced telehealth. So they know what works and what doesn't work. Now, the good thing about that is that means that the patients, the end users, and the clinicians, and those people that work with the clinicians in the healthcare service as a whole, have a good understanding of what these tools can and can't do, and then they can start leaning into them a little bit. So I think this will be incorporated into business as usual. And when that happens, you're going to see greater efficiencies for that. It's sort of industry adapting around that to make it sort of more efficient and more effective. That's going to raise interest in what else can be done. And the what else can be done is fed by the clinical, the sort of healthcare needs. So if we think about where we are with COVID right now, we're in a situation where we're still dealing with large numbers of infected people. We're still dealing with large numbers of deaths, very sadly. So we're having to continually serve remotely, number one. Number two, people who have COVID, we're very variable as to what the long-term issues are, but there's certainly a percentage of people that are going to have ongoing symptoms. There's a whole new clinical area that we're going to have to address to help rehabilitate people and care for them going forward. Telehealth has its part to play there. We've learned a lot about remote care. And so we were remotely caring for people with quite severe coronavirus in the community, and they were monitoring themselves, sometimes with wearables. That is going to be wrapped into the toolkit for everyone going forward. And then we have chronic diseases. Chronic disease care has not been completely paused, but it has been substantially paused, and cancer care. So we're going to have a big backlog that we have to work through. And then finally, we've still got the vaccinations. We've got the first round of vaccinations. We've almost certainly got more vaccinations to come on an ongoing basis. The question about coronavirus passporting and the opportunity then to deal with travel medicine as a whole. Remember, people are still carrying pieces of paper to say they've had yellow fever vaccination right now. You're going to have to wrap corona vaccine certification and testing and everything in there. So there's a lot of work to be done. And we have telehealth as a new tool to many people, but it's proved its worth. So I think we've got some really interesting times. It's a real opportunity, I think, for anyone working in this area. We all recognize that, as Umang said, we don't want to get it wrong, because this is an opportunity for us to prove how effective it can be and to wrap it in.
Thank you. I just wanted to ask a follow-up about how centralized hospitals will change over the next decade. Because, as you said, there's more focus on the end user, which is the patients. So I wanted to ask Dr. Umang if there is a role for centralized hospitals over the next decade due to this disruption.
I think what we'll end up seeing is just lots of integrated hospitals and integrated systems. So I don't know how many people are on the call at that IFA with the way healthcare set up into primary, secondary, tertiary care, but and I don't know if we've got any doctors on here or any dentists, but there's always a battle, right? Like it's incredibly tribal. So what ends up happening is if you work in primary care, you're like, okay, well, this is my world and I need to have the control of this, and secondary care, it's that. And clearly there's ever increasing demand, but only a limited amount you can spend on it. So there's always going to be those battles. I think the solution to that has to be that we move into much more integrated systems. And if you look at what Kaiser are doing in the US, and have been doing for a long time, and trying to bring all of that under one integrated system is clearly the way to go. Having said that, it looks great on paper, right? So you can draw out all of these things and it looks exactly right on paper. But healthcare is an incredibly individual, personal, people-based business. So you have to make sure you deal with all of the people within the system. So I think we'll get lots of structural diagrams and white papers and stuff saying we've got to integrate systems, but fundamentally it's about getting the right people on the ground to be delivering that care in that way. And I think that's where technology comes in and can help, right? So a lot of what we currently do is not unified. So, what we're trying to do at Babylon, if you like, is give people the first step as being a consistent, continuous, if you think about the way Google disseminated itself, is, well, actually, I know that it's very consistent. I get this and I get to where I need to go. Amazon, sort of similar. What would that look like for healthcare? Like, I know I go to this one place and then I get to the part of the system that I need to go to. So that's key for us. I think there's going to be, fights throughout the rest of the next decade about whether it should be in one big hospital, or whether it should be as a single system, or whether it should be insurance based, and blah blah blah. But fundamentally, it's about trying to unify where you can. I also think we'll end up doing it wrong. So I think medicine's very circular. So I think what we'll end up doing is we'll move to a much more bigger integrated care type system, and then in 15 years time, we'll move back to a more localized system, because you're never going to succeed fully with a single model. And I think Keith and I've probably lived through enough.
Well, yeah, I think I was going to say there's essentially an 8-year cycle. If you look at the Lansley reforms being rolled back right now in the NHS in the UK, Lansley reforms were 8 years post 2004 GMS changes, which are in turn about 8 years after 1996 changes as well. So I'm not saying put your money on another change in 8 years' time, but it is true, as a clinician, when you work in the industry, everything old is new again, every so often. So there will probably be a sort of swing back at some point, but we'll have made some ground. So some of the changes will be accepted as the way to stay forward. So, everyone has to stay on their toes.
So far in general, we've been talking about telemedicine in general and how the system will work. But I have a question that's more specific about regional trends. And Eyal, you mentioned that you guys have been expanding a lot in Rwanda. So I was just curious, what do you see as the role of telehealth in developing countries, or in countries where technology isn't as advanced as, for example, the UK? Do you think that they are going to be as able to adopt telehealth?
Yeah, so I think we can use our living example of Rwanda exactly for that. So we are talking about one of the poorest countries in the world. And I think the most interesting thing is there's no place to talk about smartphones still. And what we were able to demonstrate over the last 5 years is that if we take the logic and what we use the cutting edge technology for here in the UK, the US, and other more Western countries that we operate in, but we use the same rationale and adjust it to an area with a lower technological access, the opportunity is huge, because eventually it's more about trying to rethink how healthcare is provided. And if we look at Rwanda, so how healthcare is provided there, so there are those community centers. And obviously that's a country that is very rural in its nature. And some individuals find themselves walking for hours in order to get to the most relevant community center. So imagine the scenario where you have a family, a mother, a father that need to take their kid that woke up with high temperature and need to walk 3-4 hours in order to see see a clinician and then to stand on queue. And we have, you know, loads of evidence of how it used to look like or how it still currently look like, just in order to get treatment or just in order to get a first triage. So the very smart people that work in the Babylon operation in Rwanda, they just completely rechanged how we look at it, and also how we try to get people on board into our service, and effectively what we have today. So we have in those community centers, we have representative of Babylon, or how it's called in the regional service, Babil, and they invite people while they stand in the queue to join and use our service. Now, how the service there works, as I said, it needed to have some kind of an adjustment. So it's work based on non-smartphones, where eventually you call a center, and the same triage logic that we have in our app when we use the Babylon app here in the UK is there being managed through a nurse over the phone in a call center. And the results are quite remarkable there, because first, once you have the nurse online, in many cases, he or she can already close the loop and complete the treatment that is required. And in other cases, when it needs to be triaged and escalated to a doctor, so it can be done. And they've developed extremely efficient, really purely operational processes in how that can be done and how it's been transferred. And the results has been amazing. In a research that we've done last year, we've seen that more than 80% of the members who got a treatment were able to get a service in less than an hour. And the country average, when we took the Rwanda papers, is less than 30%, or around the 30%. So that's just astonishing. And now what we've been able to do last year is to get a 10 years contract with the Rwanda government. So we see also from the government a big desire to push for innovation. And now, as also the network is expanding, the communication network is expanding in the country, we are working closely with the government and with the regional team to see how can we, well, first strive for like more of education, and as we're going to start seeing more smartphones in the market, to start actually having like the core service that we are building now in the UK also there, but also try to rethink how can we even improve even further the existing service that is there. So I think the bottom line is that people are eventually looking to whatever going to be providing them the best service. And even if they are far less tech savvy than what we're exposed to in the environments that we are aware of, as long as you're able to provide the logic to do it and to demonstrate a benefit, so they would like to do so.
I was just going to quickly follow up what Eyal was saying as well. Just another benefit of doing this as well is that when we take our products, like for example our AI, and we localize it, we take it and make it functional in another region like Rwanda. We're increasingly using doctors, nurses, and staff from Rwanda to do that work, training them and upskilling them as well, so they become developers, not only skilled users of the technology, but developers of the technology, custodians of this technology, and being so much closer to the problems that they face in that region, are able to deliver a much more tuned solution as well. So this is work that we're doing too. It's a really positive benefit of this.
So it seems that there's a lot of room for innovation around the world. But I wanted to ask Dr. Keith if there is any market dynamics around the globe in different regions, so between Asia, Africa, Europe, North America, and so on.
It's probably an area that I know less on, so I don't know whether Eyal and Umang can say. I blessedly hide my head and work in the world of clinical digital health and so on. Eyal or Umang, are you in a position you might be able to answer this? If not, I can give my perspective on it.
Yeah, Aman, is your question more about the commercial side of it, or is it the what is it you want to know about the different dynamics?
So yeah, about the commercial side, what are the differences between the different regions around the world when it comes to actually implementing digital health?
Yeah, so my experience of it is that they're not that different, but each one has to have its own nuances. So fundamentally, when you think about delivering value back to a system, it's relatively simple, right? So you've got to improve or at least keep outcomes the same for a lower total cost. When you play that back through, you're like, well, who am I delivering value to? When you think about patients, it's exactly the same, right? For patients, it's about improving their experience for less fear. They don't really typically mind about the payment mechanics that sit behind it. Even in US systems, etc. Fundamentally, when you run well, you want to be able to click some buttons, see somebody that's going to be able to help you, and get the care you need. When you think about the clinical workforce that's delivering care anywhere, everybody wants to maximize the impact that they're having for less wastage, right? So every system in the world is not sustainable in its current form, I'd suggest. So nobody goes to medical school or does their training to not be able to offer the maximum impact. Commercially, when you get into the payers or the payer, giving value back to the system, it changes. So for that, you've got to think about, well, am I really who's really paying for this care? And there are there's three ways that care is paid for. There is self-pay. So how many people will pay just for their own appointment? And truthfully, that market globally is very small. You have to be a billionaire in order to be able to really afford it. You have to be pretty rich, because who can cover cancer treatments? Let's ignore that one. The second one is through an insurance mechanic. So you've got to work with insurers. So typically in the US, clearly that's the predominant structure, or the government. So here in the NHS. So between those two things, between the government and insurance models, are what you've got to choose between. What we do see in different markets are different mixes of that. So if you're like in the UK, it's 100% NHS effectively, with a very small bit private. In the US, it's 100% insurance with a very small bit government, the way that you worry about it. In Rwanda, they're not quite sure yet, right? So they're like, well, I don't know. Like, I've got insurance things coming up because healthcare is so important, but I've also got a state relationship to deliver. So we're not quite sure where we're going to land on that. In Southeast Asia, again, it depends specifically where you are in the dynamic. So they are more divided based on where you are geographically, as well as where you are in the social structure. So, but fundamentally, it's those two things, just with a different mix. A really interesting market is China, which I don't have any expertise to talk about, but I think the Chinese market is incredibly different because they have a new emerging way of doing it, which feels to be, it's not quite insurance, it's not quite states. It feels like if you can do it through WeChat or whatever that looks like, it's going to be a new dynamic in healthcare payment mechanisms, but that's not something that we're looking actively into because we've got our plate full with the rest of the world.
Great, thank you so much. So much happening in Babylon across the world. So thank you for all of your insights. I think we have clearly a lot of questions in the chat, and I'd love to get to those. So just one question on careers so that we can cover some of the curiosities people have is really, when it comes to MBAs or MIFs or MIMs, any of our master's students that are looking to work at Babylon, what does Babylon look for in their recruits, and what kind of, roles and opportunities for early careers in MBA students would exist at Babylon, generally speaking?
Sure. Shall we? Okay, so let's start with what are we looking for, right? So I think when it gets to MBAs or like more of the business side of Babylon, so I think there are a few departments. And well, first I'll be a little bit selfish here, but I'll talk about my team and my world, which is the global operations, which is effectively the team that either from a global standpoint, which is where I'm sitting, but also on a regional presence, actually build and provide a service to our members. And we need to have in mind that although while we talk about eventually to hear a lot about the in-app experience, about AI, eventually in the end of the day, we are providing healthcare and we provide clinical services. And it's really interesting. And as I said before, I'm not coming from that background up until the graduation from LBS. It is really interesting to say, and as we speak about the different dynamics between the different regions, once we complete a sale, once we launch into a new market, then you really get insight and understand how things are different in terms of how data is being managed. The dynamic between the services, how clinicians are being managed and their expectations. Those are all creating loads of business challenges that are very fascinating to deal with. Patient expectations also huge. You see very different when we look at our feedback and what we see from our patients in the UK, people that are historically used to be working or getting service from the NHS versus patients from New York that are based in Manhattan. Very different expectations that kind of really require you on one hand to stay loyal to the strategy that you've developed and that service pyramid and making sure that things are connected, but also see, okay, where do I need to adjust, where I need to make tweaks in how I communicate, how I get feedback, the approach to manage my clinicians. What is the service level that we are providing into our members and the cost implication that it may have. So that's kind of covering the entire operation world and where we are currently sitting. And there are always opportunities both in the regions, mainly I would say the UK and the US at the moment, but also in the team that I'm involved in or I'm part of, which is the global operations team, that is kind of more overseeing the regions and think more about how can we continue to standardize that approach as much as possible, but also working on the expansions whenever new markets are coming up. Commercial business development, this is more of Umang's domain. We had actually, so I think in the commercial world, we had people that came after an MBA and we had people that went to an MBA after spending some time and gaining experience at Babylon. So I know, Umang, feel free to jump in, but I think a lot of it is around trying to really constantly evaluate where is the value that we can provide in each potential region or in existing regions or to existing clients that we are currently providing service to. Let's remember that the vast majority of our service is B2B or B2G, if we can say in the case of the UK. So really trying to understand the market dynamics and evaluate well where the value is coming from. And then there's marketing, which you have product marketing roles, trying to think about how can we increase the brand, improve the brand. And yeah, I would say those are probably the main areas. There are also finance functions that are more, I would say, classic corporate positions. Yeah, so I would say there's quite a lot.
I think we're broadly we're split into three functions. So you're either in the build part of the business, which say Keith is in, where you're building the product or you're one of the product team and the designers, or you're in the sell part of the business, which is where I sit, which is business development, talking to partners, trying to get people onboarded. Or you're in the run part of the business, where I'll sit with clinical ops or global ops. So I think when we're looking for recruits, the main thing is trying to work out where your skill set best fits. And one of the challenges has been we're no longer a small startup that wants generalists. More's the pity, by the way. But like the challenge now is, of course, those are quite big functions that are looking with quite specific roles within them. So if you're going to go into build, we need product managers. If you're a clinician, then you're fitting into Keith's world of looking at, okay, well, how do I fit into this part? Because we've at the risk of insulting probably quite a lot of people on the call, we've got far too many management consultants in the business nowadays who love having a PowerPoint or an Excel spreadsheet that allows us to then be like, okay, we've got to fill that gap here, there, versus what it was like when there were just a few of us in the office, which was like, you're the closest to sort this out. In the sales part of the world, which sort of I cover, if you like, it really is looking for all of the classic stuff you'd expect. So we're looking for sales starters that know people in a market that will just get going. One of our biggest challenges in healthcare is that we're so universally useful. So there isn't a market in the world that we've not had some interaction with because somebody said, well, actually what you're doing would make sense for us. Our mission statement, like you saw, was affordable, accessible healthcare. That's the same as almost every healthcare provider. So our biggest challenge is trying to whittle it down into something that we can target rather than just being too diverse. So a lot of what we're looking for in Cell is for people that can come in and evaluate a market opportunity and then make sure it's primed for success. And the way that that function works is it's not just sales, you get it done and then you leave. There's quite an interlock between that and then the run process to get it up and running, because I think, as we said earlier, this isn't like, we're just going to sell you a platform, off you go. It's we're going to try and transform the way that service is delivered in this way, because we believe that's the right way to go.
Cool, thank you. I mean, it sounds like there's a lot of interesting opportunities for people who do have a business background and a lot of the different functions. And obviously, given how much Babylon has grown in the last few years, it's an exciting company to be a part of, where responsibility can also grow a lot. So thank you so much for that. And I know we have a lot of questions in the chat. So Aman, I'll hand it over to you to dive into those.
Yeah. Thank you very much for your time. And let's start with Sam, who had an interesting question about AI and the uncertainty in there. So Sam, would you like to unmute and ask your question? Sam, are you there? Okay, well, I'll ask the question. So the question was, how does AI deal with the uncertainty and lack of accuracy during triage?
All right, so that sounds like a question that I can help answer. The process of triage is based on sorting the urgency and location of the next service that this person might need, whether they can care for themselves or whether they need to go to hospital or anywhere in between. And the way that we approach that with our symptom checker is that we use what's known as a probabilistic graphical model, or PGM. And what that does is that we use medical information, medical data. We have a team of clinicians and epidemiologists to take the best available medical information about certain diseases, how common they are, how common symptoms are for each of these diseases, how likely you are to get a disease if you have certain risk factors, to populate the model. And then we built an engine which essentially asks you questions in a structured way, partly curated by clinicians. So we're using subject matter experts. My role within the company is to sort of help manage the subject matter experts that help with the building of these products. So we ask questions in a kind of traditional medical way. And then the model will then understand, based on the probabilities, what questions to ask next, and then continues to collect evidence. And once it has enough evidence, it's able to do two things. One is to give you a triage outcome, as in who do you need to be seen by and when. And then the second thing is some information about what the potential cause of those symptoms might be as well. So it's not a diagnostic tool, it's more providing information as well. Now, medicine is often described as an art as much as a science. And whilst we all work very hard to sort of get to the absolute ground truth of things, that a person has some symptom, it must be due to X, there's still quite a lot of different ways towards that. And so human clinicians will learn through their training and through practice how to ask questions to get the right information, then to establish some theories as to what the diagnosis might be. And then importantly, when they're making a decision, to safety net, to understand, well, look, if I think this is a person who's got abdominal pain, it might just be a mild tummy bug or gastroenteritis, but could it be appendicitis? You ask questions to try and rule that out. And even then you might then say, well, actually, you either need to go to a place because it's safer, even though the likelihood is low, the consequences of getting it wrong are high, or you tell a person to take care of yourself, but if any new symptoms arise, then act on them. So when it comes to managing the uncertainty of this, we do really much the same inside our model. We have kind of utility approach, looking at the different potentials. So person has abdominal pain, maybe it's gastroenteritis or a viral infection. There's a very, very small chance it might be appendicitis. However, the consequences of missing that are quite big. Therefore, on the balance of probabilities, you should go to hospital. We also have human rules put on top of this as well to make sure that if there's common practice, and a good example of that might be chest pain. There are certain forms of chest pain where you would very, very rarely not manage that person by seeing them face to face. And then you have safety nets in there as well. You know, you give person information, but make clear that if there's any change in their situations that they can get back in contact. And that's one of the benefits of using AI or a symptom checker as opposed to a human in the loop, because the symptom checker is continually available 24/7, 365 days a year, whereas the ability to get back in touch with a clinician is sometimes limited on time of day and so on. So it is tricky. There's no two ways about it, but there's definitely methods you can do to help reduce the risk. And sometimes that's erring on the side of caution, but it's all informed by subject matter experts in the best medical practice.
Thank you, Dr. Keith. Ramsey, would you like to ask your question? So the question was, are there applications for mental health patients in addition to your current physical health coverage?
Yeah, about, so I think mental health is the crisis that we're all going to have to face. I don't think we've got the solution to it. So I think there's, I think about 10% of our GP appointments in the UK are for mental health, and we think that's underreported. I don't know if AI is going to play a big part in that. I think that we're at the very beginning of trying to understand how we deal with mental health. I think what we need to start doing is treating it a bit like we did when we know so much about heart disease as an example. So we now need to start again at the beginning with mental health and think, how do we get to that basis of knowledge and really build for the future? I think anybody that says they've got a quick mental health solution today is slightly deluded. I don't think it's just talking therapy on the phone. I don't think it's medication. I think it needs a whole host of stuff. I think from Babylon's perspective, I think we can be useful, and we're definitely looking at it. But I actually think there's a load of startups that are going to really thrive in this space and do stuff that, when your single focus is mental health, I think that's what you need. Interestingly, very early on in our history, we had quite a serious debate when there's probably about 50 or 60 people in the company about whether or not we should just be a mental health company and completely pivot away from doing primary care and just do mental health. And of course, we made the decision to do primary care. But I think it's that sort of organisation that's going to really take things forward for mental health. And I would hope that from a Babylon perspective, we can then partner with those organisations to help them scale faster and more efficiently.
I think it's important, obviously, to remember that artificial intelligence is one particular tool, very large and powerful tool, but one tool in the digital health tool set as well. So AI may have its part to play in helping identify patterns in data that's out there, and that may have some mental health applications as well. But actually, something as simple as providing trusted information, and for people who suffer from anxiety disorders, the ability to be able to do a video consultation from a place they feel comfortable, as opposed to forcing them to come down and wait in a busy waiting room. This is something that actually, when I started using video consultations before coming to Babylon, that was the main problem, is that I'd have a walk-in center and I'd get a person who had very severe anxiety to come down and wait in a room full of people that were extremely unwell and unhappy for 2 hours. That's a very uncomfortable thing to do. And we shouldn't be asking our patients to do that. So I think digital health has an enormous amount to play. Umang's absolutely right. There's some fantastic startups and other companies in the space. And we would hope to maybe incorporate the best solutions for the people that we work with.
Great. So Laura had a question about your partnerships with other companies around the world. So the first question would be, do you have partnerships with different companies around the world? And second would be, do you offer any softwares to different businesses, and to what extent?
Yeah, so we have lots of partnerships with lots of people around the world in various guises. Here in the UK, we've got our NHS partnerships, we've got partnerships with Bupa, we've got partnerships with NHS hospitals. In America, we've got partnerships with the likes of Centene and Mount Sinai. In Southeast Asia, we've got partnerships with Prudential and so on and so forth. Each one of them varies because clearly they're all different types of providers. What was the second part of the question on? Sorry, that was...
Yeah, the second part was, do you have any software that you sell to different companies around the world, and what kind of softwares would they be?
Yeah, so we do. So it's fascinating because we debate this constantly about, are we a service provider or a technology company. And I reckon, and we're somewhere near 50-50. For people like probably the three of us on this call, we like being a full end-to-end service provider and doing everything because that's in our DNA. As we've grown, we've just got a new chief business officer, for example, who's come from Google Cloud and from Dell, who's very much keen on trying to promote the software as a service line of business that we've got going as well. So we do sell our symptom checker, for example, as a standalone product. We do that in Birmingham. We do that a little bit in the US. But fundamentally, our core bit, and as I did in the presentation, we're much more interested in our Babylon 360 model, and but that's very consuming. Probably as we grow up and get more mature, we need to start thinking a lot more about our software model too. But it's not core DNA stuff. We never meant to be a software house. So, I think we'll have to be what we are, and then there'll be a software component to it, which has started in earnest probably earlier this year.
Yeah, and I
So
think
the next question. Go ahead, Eyal.
So I was just about to say that I think a good equivalent here might be some of the products that Google over time has started to sell. So for example, Gmail that initially was designed as an internal tool. So I think in a way that's kind of like how we think. We are thinking first about our patients, how we can provide a holistic end-to-end service while being efficient and advanced in how we develop the tools to actually provide it, that then effectively we could outsource or sell.
Okay, so the next question was asked by Grace. So in the UK, a lot of GPs are referred to as gatekeepers. So they see the patients initially, and then they will refer patients to specialized doctors. So this is more about primary care physicians. So the question is, how does Babylon see itself working alongside or replacing primary care physicians?
I can just give a little context, just as like something that I've noticed. I work in healthcare. Having a different GP every time for a video consultation makes this kind of practice very difficult. So I'm just curious at like where Babylon sees itself heading or supporting this like trend in healthcare.
Yeah.
Shall I answer from a GP perspective? There's something very important about continuity of care. Continuity of care is in part how the NHS achieves so much with relatively little in terms of costs, partly because the GP is the gatekeeper and the idea of the cradle to grave record, the relationship and so on as well. And that's fantastic, and it can allow for some really incredible care, but it's also extremely human resource intensive. And working as I did as a GP in a walk-in center where I was seeing patients that had urgent issues, I was frequently seeing people that couldn't get any issues addressed because they were restricted in their practice. They could only see their GP. That was enforced by the practice, and their GP didn't have an appointment for 4 weeks because they were booked up seeing people as well. So how do you get the benefit of continuity but allow for the flexibility? And that's something that we work very hard on. And part of this is about continuity of data, making sure that the information that's required for a person, for a clinician to work with a patient to make the correct decision is presented in the right way. So a continuous digital record that's available and summarizes it helpfully. That's something that we work on within our product as well. Second thing is making sure that one of the areas that we're working on is having a care plan approach. The idea is that you have a sort of agreed approach to all the conditions that you might have as well, and making sure that that's a kind of shared document or a shared resource. We're working quite hard on that area as well. And then the third thing is just identifying when continuity is important. I mean, simply speaking, if a person has an ear infection, in some ways they don't mind who they see as long as they see someone quickly. But if they have something that's affecting, that has a sort of multi-area input, like social issues, mental health issues that relates to their relationship with the rest of the family and so on, then some continuity might be important. So we have the ability within our application for people to specify that they want to see the same clinician again. That's very important for people who have mental health issues because they maybe don't want to have to go through the same story again and again and again. So it's about again, trying to find the right service, the right thing at the right time. And part of that can be automated, but part of it also, it's always about getting the right person in place and augmenting the humans. So that's a rather rambly answer, but hopefully at least gives you some insight into how we're trying to approach this, trying to make the data continuous, and then when the human continuity really matters, trying to make that available.
Yeah, I imagine data is a big part of that. Thank you.
No problem.
So, Owen, would you like to ask your question?
Yes, thank you. So actually my question was a bit touched on earlier in the presentation. It was about does Babylon cope with the changes in healthcare system and culture of each country that it expands to, and how? But I did hear a bit of that earlier. So I want to ask one more question. What does it mean in the map that you showed earlier in the presentation, in which you signed with some countries? So what does it mean to sign,
Yeah, sure. So it's a heavily regulated industry. So we've divided it to three, right? There are the ones that we already operate in. There are the ones that we've already signed some kind of an agreement that obviously we can commercially share externally or has been already shared externally. And the ones that we are evaluating. And I think that's what we said about the work around, or the pre-discussion, the pre-sale work that needs to be done around identifying, really analyzing the market, understanding where is the value that we can provide, and then build the value proposition and the service that will be relevant to make those sales conversations. So the interim stage is that agreement effectively that we have, but we are not live in those areas.
And just want to follow up. So what does that mean for, career perspectives? Because I come from Southeast Asia, Vietnam in specific. And you just sort of sang my country, and it's a bit, I know that this market in Vietnam is a bit, new, and it's a bit hard to get in as well, because it's really regulated. And in terms of AI, it's really hard to build the kind of neural language programming for Vietnamese language as well. So what do you have any thoughts on that?
Well, the good news is that we already have an office in Southeast Asia, and it is a big strategic focus region for us. So there are already opportunities there. I don't know where you are currently with your post LBS plans, but and I'm happy to follow up on that outside of this conversation. But I would start by checking online, because I think there are quite a few live roles that are already in our job board. So I would start from there.
Okay, thank you so much.
I was going to come in and say that actually I had the opportunity to present to some ministers from Vietnam actually that came across back pre-COVID, and so they were asking a lot of questions about some of the questions that you raised about natural language processing for the Vietnamese language, about localizing and so on. So they already had some quite advanced understanding and some sort of shrewd questions about how these technologies would be best used for their population.
Well, I think we're running out of time. So I recognize there are some questions we didn't get to address. So if people have those specific questions, you can reach out to me and I can funnel them along. But Eyal, Dr. Keith, Dr. Umang, thank you so much for your time. This has been very interesting and informative for everyone. So really appreciate you taking the time.
Thank you very much.
Thanks for having us.
Take care.
Thank you.
Yeah.